All right, I think we have reached our critical mass and we can start. Again, good morning, ladies and gentlemen. Welcome to the Medicine Safety webinar, titled Increasing Awareness and Reporting of Adverse Events. My name is Sibusiso Hlejabo. I'm the Director for External Affairs at PATH and also a member of SAHPRA, which is a coalition that does public health advocacy. As I've mentioned, this webinar is titled Medicine Safety, and it looks at increasing awareness and reporting of adverse effects. In September, the world commemorates World Patient Safety Day and World Pharmacist Day, which are observed on the 17th and 25th of September, respectively. And it is in recognition of these important dates that the South African Health Products Regulatory Authority, SAHPRA, is hosting this webinar. The World Health Organization's theme for 2022 for World Patient Safety Day is Medicine Safety, with the slogan Medicine Without Harm. And it aims to focus attention on emphasizing the need to adopt a system and approach that promotes safe medicine practices free from harm. And the 2022 theme has vast impact on public health because of the burden that harm associated with the risk of medicine or medication errors has on medicine users. And then the purpose of the annual World Pharmacist Day is to encourage activities that promote and advocate for the role of the pharmacist in improving health in every corner of the world. This year's theme is Pharmacy United in Action for a Healthier World, with the aim of showcasing pharmacy's positive impact on health around the world and further strengthen solidarity amongst the profession. As you all know, SAHPRA is mandated by law to oversee the safety, quality, and efficacy and performance of all health products that it regulates. It therefore ensures that all adverse events, including medication errors, are invested, monitored, analyzed, and acted upon. This webinar will focus on increasing awareness and reporting of adverse events, including medicine or medication errors as we create a healthier world. We've got an esteemed panelist that will be making presentations today. And the way we're going to do the webinar is we will receive presentations, and we'll also have a chat that's going to be opened where you can pose questions. Due to the nature of the program, our panelists will start responding to the questions that will be posted on the chat. And we hope that we will have 10 minutes at the end of the presentations where we'll have a Q&A where panelists will respond to questions on the chats that will not have been attended to. So it is my pleasure then to invite Professor Mark Blockman to give us our opening remarks. He's the medical specialist and professor, clinical pharmacology at the University of Cape Town and Pretoria Hospital, and chairs the Pharmacovigilance Committee at SAHPRA. Over to you, Prof.
Good morning, everybody, and thank you very much for joining us. I'm just going to share my slides, if you give me 1 second. You will tell me if that's okay?
Yes.
Brilliant. So thank you very much for joining us, and I'm just going to give you a potpourri of medication safety and some thought processes around maybe some systems, and just to highlight how important this is to all of us and how accountable we are all to our patients. So this is just a slide in terms of what the risks are in terms of encounters, and you can see that 1 death per 1,000 encounters is healthcare. So we don't do so well. If we look at this, 1 to 2 airline crashes daily versus 44,000 to 98,000 deaths annually due to medical errors. Now, the question is, would you go and see a doctor, and would you take any prescription medicines if you actually read that? So from the 1950s all the way up until 2004, it took a huge amount of time for people to realize how dangerous medicines are. And basically what happened is that there was the Betsy Lehman Medication Safety Center. She was prescribed the wrong doses of anti-neoplastic medicine and developed a severe adverse event and was fatal. And they then opened up a safety center. But look at that gap between understanding chloramphenicol causing aplastic anemia, and 2004, the Betsy Lehman Center. But just look at this, how big is the problem? In 1970, 3% of all admissions was due to adverse drug event. And look at this comment, the rates and severity of adverse drug reactions to individual drugs are remarkably low in view of their pharmacological properties. Already at that time, people were fearful that, that there was going to be a risk. If you look at some more recent data, if you look at around 4 to 6% of patients are admitted into hospitals due to an adverse event, and there's consistency from across the world, and I'll show you that now. When we look at Australia, 2 to 4% are due to medication errors, people coming into hospital. And look at that, previous drug allergy history not recorded in greater than 75% of the time. And that to me is a simple aspect in terms of a system of understanding if somebody may or may not be allergic to a medicine. In the United Kingdom, they found that 6.5%, with 80% being directly the cause, and there was an increase in bed stays with a huge amount of money at that time projected to cost the NHS. And look at this, again, the drugs that we usually use, aspirin, warfarin, diuretics, and the usual culprits are non-steroidal anti-inflammatories. And drug interactions accounted for about 17%, and I'll get back to that a little bit later on. This was recently published, and this is again from the United Kingdom, and sorry for the busyness of the slide, but if we look at this now, 16.5% were ADRs accounted for total admissions, and people were taking more medicines when they had an ADR. And basically what they suggested that 40.4% of the ADRs were avoidable or possibly avoidable at that time. And again, look at the medicines: anticoagulants, antiplatelets, proton pump inhibitors, and chemotherapeutic agents, again with a huge amount of cost to the NHS. And if you look at this on the right, the conclusion that they talk about is that it's placing a huge burden on patients and the healthcare services, and reducing inappropriate polypharmacy should be a major aim for preventing ADRs. Again, a system for us to be able to understand what the risks are when we prescribe more than one agent to a particular patient. Our experience was 6.3% at Somerset Hospital. When we looked again at 4 medical wards in South Africa, we found 8.4% of the time people were being admitted due to an ADR. And in-hospital death was almost 20% of patients in the medical wards were being, the cause of death was due to an ADR in the hospitals. These are terrible statistics, and one needs to take this in very carefully as we move forward. And 50% of serious adverse events were preventable. Again, this talks to, is there a system that would help us to prevent these adverse events and deaths? In children, 1 in 10 are impacted by an error, and 35% of these errors are serious or life-threatening, and they are 3 times more likely than adults to experience harm from medication errors and adverse drug events. So often a forgotten population are the children. And if you just look at this very busy slide, if we just look at this, 3.8 per 100 drug exposure admissions, 23% is preventable, and 20% fatal or near fatal serious adverse events for pediatric populations. Begging again a system for us to be able to prevent or to help each other into preventing these ADRs. And why are the kids at risk, the pediatric populations? Well, different pharmacokinetic parameters, they're not small adults. One has to be flexible in terms of calculating what the dosage are, age, weight, body surface, and clinical condition of the patient. Much more difficult in the child. Lack of the dosage form, so we guess and we make it up. We also need precise dosage measures and appropriate drug delivery systems. They're not always available for the children. And sometimes the actual information from the FDA or SAHPRA are not available to the prescribers, or they don't have them easily accessible for them to make decisions on prescribing in children. What about polypharmacy? Okay, it's a major risk, and I just showed you that Pierre Mohammed in the UK showed the same data. 16.5% of ADRs were causing admissions, and polypharmacy was the major risk for this population group. And a while ago, people said giving a drug that interacts. was a major risk in terms of primary health care. Again, talking to the fact, is there a system? Is there some cheat sheet that could be available to help people prescribe? Some data show that 3 to 5% of preventable ADRs were due to drug interactions and were a major contributor to the casualty environments or emergency care admissions into hospital. Again, drug interactions. In 1980, when I was around, medical school graduates needed to really know about 60 drugs well. 2006, this number is estimated about 700. Can you imagine what this is now? And the drug-drug interactions increase exponentially with these numbers. Just look at this, and it's not unusual to have 8 medications leading to 28 potential drug-drug interactions. Somebody with diabetes, ischemic heart disease, and hypertension, you're very close to the 8, or heart failure, you're very close to the 8 agents that somebody's going to be prescribed. And what about these safety tools? Memory and best efforts, holding up and saying, I hope I know what's going on. Dear doctor letters, people don't always read them. Package labeling may be a bit small for people to read, and they don't always read them. Electronic medical records, now that's really important. Having something accessible on your phone or your desktop would be very useful to actually have that information at the drop of a hat for you to be able to make a decision, especially allergies, for example, and previous prescriptions and what they're being prescribed. And then drug use review to guide us. How are we doing? Are we doing well or are we doing poorly? And what are we actually doing in terms of harm? And I thought this is really important. Asking an individual doctor to rely on his memory is like asking a travel agent to memorize airline schedules. They never do that. They have systems, they have computer systems to do that. And yes, some of the drugs removed from the market due to drug-drug interactions causing torsade, a fatal ventricular escape rhythm. And these are very common agents that people will be familiar with. And here's the fatal arrhythmia that occurred and puts people at huge risk of ventricular escape rhythm due to a drug-drug interaction, pushing the level of the other drug up very, very high, leading to cardiovascular outcomes. The cisapride, if you just look at this, withdrawn by the FDA in 2000, more than 70 fatalities. And the adverse event was due to taking cisapride and another drug from a drug-drug interaction, pushing cisapride up. Okay, and so that, just look at how many people had to die before people realized that this was a major risk to patients. What's the problem? Well, clinical trials are a major risk because they don't have enough people enrolled, 3,000 to 5,000, and a lot of the population that we often prescribe in are excluded. The elderly, people with renal disease, liver disease, children are excluded from these clinical trials. And these are very closely monitored patients, so often we don't get the true adverse event profiles. And so just look at the exposure on the left-hand side for the drugs that are removed from the market. Look at the exposure in the studies and the exposure, 10 million for rofecoxib before it was removed from the market. And you can see the increased number of patients which you have to be exposed to before one gets the understanding of the adverse events. Okay. And so what has EP said?
You've got 1 minute.
Thank you. Medical error is not fundamentally due to the lack of knowledge, but not putting our knowledge into practice. So what's the way forward? Well, avoid mistakes, allergies. We must have vitamins and herbs. Don't forget old drugs and OTCs. Don't worry. And we must obviously be important about interactions. Okay. So this is what we need, is a high level system to do that. Having a process, electronic prescribing, some check level to help us make decisions. So Harry Truman said, doing the right thing is easy, knowing what it is more difficult, and the best way to build the future is to create it. Thank you very much, and I hope you enjoy the webinar.
Thank you so much, Prof. And thank you for sticking to time and also outlining the problem and also ways to address the problem. And next on our program, we'll have Ms. Busisiwe Mosane. She's the Medicines Control Officer at SAHPRA. And she'll speak to the role of SAHPRA on World Pharmacist Day and promotion of medicine safety. Over to you, Ms. Busisiwe.
Thank you, everyone. Just share my screen.
We can see the screen.
Right, thank you. So I'll be talking about the role of SAHPRA in medicine safety. Let me first start by talking about the what SAHPRA is. SAHPRA background is the South African Health Product Regulatory Authority, and it was established in 2018, and it replaces medicines as Medicine Control Council, as well as the Directorate of Radiation Control, as it also regulates radiation emitting products. And SAHPRA promotes public health and safety by ensuring that all health products, including medicines that are available in South Africa, they are safe, they are effective, they are of good quality and acceptable performance. And then coming to safety, pillar of the authority, SAHPRA monitors risk factors associated with medicines through pharmacovigilance. And pharmacovigilance is basically means the science of ensuring medicine safety by the detection, the assessment, understanding, and prevention of the adverse events. So Prof. Brockman already touched on the limitations of clinical trials, but I'll just want to talk about it a little bit, as it shows what the importance of pharmacovigilance is. So before the medicine is authorized for use, evidence of its safety and efficacy, it is limited to results from clinical trials where participants are selected carefully and they are followed up very closely under controlled conditions. So this means that at the time of the medicine's authorization, it has been tested in relatively small number of participants for a limited period. So let's look at when this pharmacovigilance started, or when was it established. Following the thalidomide disaster in the 1960s, where babies were born to mothers who took their medicine, they were born with deformation of limbs. So in 1968, the World Health Assembly made a resolution to establish a systematic...
Yes? Interrupt the presentation. If possible, would you mind switching to the presentation mode? If it's not too much trouble on your end, thank you.
Okay. All right, let me stop. Sorry about that. I have to stop sharing and share again. Is that okay? Hello?
Can
No,
you
we
share
can't.
the screen? If you can share the screen.
You've stopped sharing altogether.
It's still the same, or do you see anything?
Still nothing. Let me try sharing from my side.
Thank you very much. Sorry about that. I think I was on slide number 11.
Is it here?
Some of the slides I have hidden, so we can go further down. Again. Yes, that one. Thank you. All right. The pharmacovigilance was established after the thalidomide disaster in the 1960s. And the World Health Assembly made a resolution to establish the system for collecting serious adverse drug reactions. And this is where it led to the Program for International Drug Monitoring. And this program, next slide, please, is managed by Uppsala Monitoring Center. And the Uppsala Monitoring Center is responsible for, among others, the collection, the assessment, communication of information from member countries about the benefits and the risks associated with medicines. And also the improved patient therapy and public health worldwide. Next slide, please. The UMC has developed a global database, which is called VigiBase for these member countries. And to date, we have over 32 million reports available on the global database, of which 68,000 are from South Africa. And this is from 1993. Next slide, please. To date, as seen on that slide. Next slide, please. The next slide shows the qualifications of reporters. Most of these reports were reported by physicians at 57.7%, and only 3.5% were reported by us pharmacists. So we can go to slide 18, please, where slide 18, this I've hidden. Can you go to the next slide? And the other slide. Next slide, please. Thank you. Where we are going to talk about reporting tools to SAHPRA, which reporting tools we need to use to report adverse events. So we've got a number of them. There is MedSafety app, a reporting tool, which is downloadable on the SAHPRA smart mobile phone, and is available on the SAHPRA website on the link there. And the next reporting tool on the next slide is the ADR form, which is available on the SAHPRA website as well. It needs to be downloaded and printed, completed, and upon completion, it should be sent to ADR@SAHPRA mailbox. We also have, next slide, please, the e-reporting portal on the SAHPRA website, available on that link. And with this, you are able to get an acknowledgement letter once you have reported and completed reporting. And can we go to slide number 23, please? Thank you. So after we have received all these adverse events, including the medication errors, what is it that we do as the regulatory authority? When safety concerns are identified from the reported adverse events, the overall benefit risk profile for that particular medicine is considered to ensure that benefits outweigh the risks. So based on the assessment, the regulatory decisions are made and communicated to relevant stakeholders. So this would be your healthcare professionals with the healthcare professional letter, and also product label change as well would be made, where we would have to communicate with the pharmaceutical companies to effect that. So yes, and the others that recently have been publishing on the website are the press statements on the COVID-19 adverse events following COVID-19 vaccines. So the next slide, please. Before I get to that, there's actually a summarization that I would include the slide deck on the role of SAHPRA in medicine safety, because we basically collect the adverse events, collect and collate them. We analyze them and assess them for to identify any emerging safety concerns. And then after the safety concerns have been identified, we communicate the regulatory decisions with relevant stakeholders. And also that would also lead to prevention or mitigation of these adverse events from occurring in the future. And on the slide on confidentiality, it's just to encourage healthcare professionals to say that SAHPRA maintains confidentiality at all times regarding the identities of patients and the reporters. So healthcare professionals should not be afraid of reporting, thinking that that will be taken as an admission that the reporter has contributed to the adverse event. So in my closing on the next slide on conclusion, I am saying that if there is any doubt about whether the adverse event should be reported, it is always best practice to submit a report, because every report matters. And by reporting, you improve safer use of medicines in the country. So thanks everyone for listening to me. Thank you for your time.
Thank you so much, Lucy, for giving that SAHPRA perspective and also guidance in terms of what needs to be done. I think next on the program we'll have Mr. Yusuf Dawood. This is Sanofi representative and pharmacovigilance Southern Africa safety head. Over to you, Mr. Dawood.
Good morning, everyone, and thank you for this opportunity. I think I'd just like to go ahead and say that from a disclaimer perspective that these are my own views and they're independent of Sanofi. To start off with, I just want to go through what are pharmacovigilance and why medication errors. So as Busi mentioned, that pharmacovigilance is a science related to detection, assessment, and understanding and prevention of adverse effects. So what I'd like to get across here is really that it's a science that goes behind it, and it's not just reporting, etc. There's a lot of data that needs to be collected, a lot of analysis that has to go through in order to prevent medication problems that happen to our patients. And really to touch on medication errors, as it is the theme, one of the themes of today's presentations. And when we look at medication errors from various different health authorities, we see, for example, from the FDA, where it's a preventable inappropriate use of medication or harm, the EMA definition, where SAHPRA also expands further on the definition from the EMA, where, and we really find that from here, it's preventable medication errors, as well as mistakes that can happen. So what we're trying to do is to educate patients, and we are trying to educate healthcare professionals, including pharmacists, in order to prevent these type of errors from occurring in the first place. So we then go on and say, why exactly are we talking about medication errors? And from World Patient Safety Day, which was held on the 17th of September, we find that it's the World Health Organization's theme for this year is about preventing medication harm. So one of the main reasons for that is medication errors. And there have been many different webinars, education materials, etc., or a lot of social media posts that have been put up regarding medication errors, how to prevent it, how to spot it, how to educate our patients. And as pharmacists, we really play a very core role in this particular aspect, where a little bit of education can really go a long way in preventing harm. So when we look at what type of medication errors there are, and we find that there's many reasons as well. One of the reasons are that the HCPs, including pharmacists, including doctors, nurses, etc., sometimes do not understand the use of the medication, or they do not explain it correctly to the patient. The second part is where it's related to the patient's lack of understanding, the patient's forgetfulness, as Prof mentioned earlier on. It's really important that the patient has full knowledge of how to use their medications, and that's where us as healthcare professionals really need to be at the forefront and take the medication and the patient safety to heart. The last is where there are certain instances where the medicine may be at fault due to various reasons, and one of them may be because of packaging, one of them may be because of incorrect dosages or quality defects, etc., that may cause harm to the patient. And as Prof. Blom also mentioned, there can be a lot of deaths associated with medication errors. But one thing that we really do see is that there's very low reporting of medication errors that come through to us. And in the first slide, you'll understand why we require this type of information, right? And the amount that we are receiving now is very few, whereas the actual amounts go up to 40% of certain medication errors are not even reported to whether to the health authority or to the pharma companies, in order to go right to the first point again, where we talked about prevention of harm to our patients. So you as a pharmacist, where exactly do you fit in here? And I know I'm talking to pharmacists from across the board here. Pharmacists really, whether you are in industry, whether you are in academia, in retail, in hospital, in research, wherever you are, you still are the custodian of medicine. It is your responsibility, it is your duty in order to make sure that medicine is always taken in the best way for the patients and to prevent as much harm as possible. And patients are always educated. Another reason why your role is so important, especially in a community setting, is that you are the most accessible healthcare professional. There's always appointments for nurses, for doctors, etc. You always have to go through some sort of system. Whereas a pharmacy, you walk straight in, and that information for regarding your medicine use and regarding your health is very rapidly available to you. So as pharmacists, what we need to be looking at is in the healthcare settings to detect. So when a patient mentions something to you, use your knowledge, use your expertise in order to detect whether this is an adverse event or whether it is a medication error, right? And report that whether to SAHPRA, whether to other health authorities, whether to the pharma companies, in order for us to prevent our patients from harm. The next part about it is really comes to your role to a lesser extent, but to the pharma and industries and the regulatory authorities' role in here is that for the assessment and understanding of how these medication harm patients, so these adverse events, etc., how the use of the medication in the wrong ways, what can happen and how is it contributing to the harm of patients. That sits with pharmacists as well in industry and in the regulatory authorities. And then our holistic aim is really to prevent any further harm to our patients. So using all of the information that we receive from the healthcare professionals, from pharmacists, from consumers, we then develop strategies in order for the medicines to no longer be or to reduce the amount of harm that the medications can cause. So when I go back onto what the pharma industry's role is, it's really to train and educate pharmacists and HCPs, but I would also add consumers in order to use medication in the correct way. Pharma companies further in the industry, really what we do, and talking back to the ADR app from SAHPRA, the Vigibase, etc. Pharma companies really play a very important role in collecting and reporting of adverse events, whether it's to Uppsala, whether it's to SAHPRA, etc. So and it comes from various routes, spontaneous reporting, where you find something is just wrong, or you find a medication error has occurred, you spontaneously report it. And we've got digital programs, we've got patient programs, we have market research programs from various companies where this type of data is collected and analyzed. And specifically when it comes to medication errors, beside any of the other adverse events which are also reviewed, medication errors and the cause of patients using the medications in the wrong way, and remember, in an unintended, they don't mean it, it's a mistake. So we gather the information, we analyze it, we try and figure out what's going on through various processes of signal management, periodic reports, risk management, etc. Then we really have from pharma industry through various interactions with HCPs in order to educate and bring attention to medication errors. Then when it comes to receipt of complaints or medical inquiries, sometimes HCPs have a complaint about the quality or something of the product, or they have a medical query regarding how to use a particular product. And with that, there's normally an underlying adverse event as well. So by analyzing correctly, we are able to draw on that type of information to provide better risk minimization measures. And working with SAHPRA, we actually come up with very, very good risk strategies, risk minimization strategies that contribute a lot. So it's about education, it's about dear healthcare professionals, letters, it's about patient materials, patient cards, updating the labelings, etc. That collaboration that we have with the health authorities and with HCPs really, really prevent risk going forward. But again, the amount of reporting is quite low. So in order to increase the risk, or for us to better understand the risk associated with medication errors, we do require all pharmacists to provide information to us more proactively as well. Then, just as a last slide, just to know that how do pharmaceutical companies commemorate World Pharmacist Day? And we really do this internally as well as externally. And yesterday, I know I'm showing a lot of stuff from last year, but yesterday was World Pharmacist Day. And we should really be proud of this particular day because we are still the custodians and the ones responsible for medicines. So via social media, you can go onto any social media platform and you'll be able to find many different posts from pharma industries, from pharmacists, from regulators, etc., on how what the pharmacist's role is in patient care. We also have Pharmaco.
You are on time, Mr. Yusuf. Please conclude.
And we really collaborate with the pharmaceutical bodies and regulatory bodies in order to promote World Pharmacist Day as well. Thank you.
Thank you so much for sticking to time. And next in our program is Mr. Isaac Nkanyane. He's the Senior Manager at SAPC, and he'll speak to the role of SAPC in the promotion of medicine safety. Over to you, Mr. Isaac.
Thank you very much, colleagues. If I can have someone to just flight our presentation, please. Thank you very much. If you can go down, I think we have 6 slides from ourselves. Thank you very much. As you know that Pharmacy Council is a statutory council which is established in terms of the Pharmacy Act. And those are the listed objectives of council. I won't go through them one by one. If we can go to the next slide. Thank you very much. In relation to patient safety, council has a lot of public awareness, and one of those is the patient's rights and responsibility posters, which are mandatory to be to the pharmacies or to the community and hospital pharmacies, so that they are displayed visibly in community and hospital pharmacies. So in this patient rights and responsibility posters, we have all the rights which the patients needs to know in respect of what to do when there's a specific issue. If you can go to the next slide. We also do media campaigns in community radio station to educate the public on the role of pharmacy. And we also do social media campaigns through webinars and through the other social media platforms. I think the target for the community radio is just to reach as much as more people as possible. As you know that more people who are living in villages, they might not know what is happening. They might just say, when you go to the pharmacy, you just get the medication and you go home. And for us who are from the villages, we see a lot of people drinking medication and also drinking alcohol, not adhering to the instructions which are given to them by pharmacists. And this can also not only happen in the pharmacy, can also happen in the clinics in villages, as most of the people who are in the villages, they receive their medication in the clinics. So we do public awareness in most of the community radio stations so that we can educate most of the people who are in the villages, so that we cover them, we don't leave them behind, because more of the emphasis in most cases will be more of people who are in the urban areas, and those that in the villages or in the rural areas are left behind. So hence we target more of the community radio stations. Thank you. We can go to the next slide. So we also have the pharmacy month annually together with the Department of Health and the associations. We do the National Pharmacy Month awareness campaigns, and most of the themes, if you have been following the Pharmacy Month, it's always around the medicine safety and the correct use of medicine. So we have been participating in these pharmacy months for long. It has been a good initiative from the Department of Health, which we also part of it, and together with the other associations. If you can go to the next slide. In relation to professional conduct, we don't only punish people, we also encourage professionals to adhere to the legislation. We have just given examples here, which relates to the Schedule 1s and 2s in terms of keeping the records of 1 and 2s, mostly around the codeine containing medication. So this will also other things which to say in terms of Section 22, A5B, that the pharmacist will be required to authenticate the prescription just to reduce the medication errors. also to avoid dispensing errors which are caused by eligible prescriptions. I've seen a question that most of the health colleagues in the HPCSA, they are rude in terms of when they are contacted by pharmacists just to indicate to say, what medication did you prescribe? So in most instances in relation to that, it seems as if we don't have an immediate relief for the pharmacist. How do pharmacists deal with that when the doctor is so very rude? Because if you say report the doctor to HPCSA, that will not solve the current situation which you are facing as a pharmacist, and you are left alone just to deal with a prescription that is very eligible. I think it is in terms of the electronic prescriptions. Maybe if we have, you could try to contact the doctor, you can just provide him with an alternative to say, this is my email. If you can send me the electronic one so that I can dispense the medication. I think that would be the immediate relief for that. If you can go down. In terms of good pharmacy practice and ethical rules, you will note that Pharmacy Council conducts inspections every year. So the inspections are conducted in relation to the grading. If you are a grade A, that means you will be inspected in 3 years. If you are a grade B, that means you will be inspected in a year. If you are a grade C, that means you will be inspected until you comply. So you will be inspected every year until you comply with the good pharmacy practice. So the GPP and the ethical rules guides and enforce the ethical dispensing to ensure the safety of the patient and to avoid dependency and addictions to patients. As you will note that ethical rule 1 requires that the pharmacist must provide advice to the patient for the effective use of medicines. And also you will note that GPP 2.7 in terms of labeling, it requires the pharmacist to label the medication with the instructions so that the patient can follow the instructions. In relation to unprofessional conduct, when we detect the unprofessional conduct through inspections or complaints that we receive from the general public, and those complaints are dealt in the disciplinary committees of council, where we enforce appropriate sanctions. So we don't necessarily only enforce sanctions. There are instances where a patient will go to the pharmacy and say she requires this type of medication, and the pharmacist will say that this person, the time frame in relation to when this person must get the follow-up on the medication, it's not yet expired, and then the pharmacist will refuse dispensing that medication. So we do write letters to those pharmacists to adhere to the legislation and to the good pharmacy practice to say, thank you for upholding the profession in good standing. Can go to the next slide. Oh, that was my the last one. Thank you very much.
Right. Thank you so much, and thank you for sticking to time. And next, I'll encourage participants to continue to put in questions in the Q&A chat, and we'll have Dr. Matlala, a lecturer, public health pharmacy and management at the Makgatho Health Sciences University. Over to you, Dr. Matlala. Madam News, we can see the slides.
Morning, colleagues. My apologies for the delay. So when I'll just start by maybe giving you perspective of where we come from or how we prepare students or future pharmacists in, I can't move my slides, to be practitioners. Okay. I think what is important is for us to bear in mind that as healthcare professionals, pharmacists, their main responsibility is to ensure that patients have medication that is safe. And we also have to ensure that we identify and prevent potential prescribing and adverse events. That is, I think, a primary purpose in training of students or practitioners. And so this responsibility falls on us as educators. And we do through the various ways of delivering the education, carrying out research, and actually participating in practice to make sure that we prepare professionals that are up to date with information. It's also important to then remember that for us to be able to deliver a program, we have to follow, or the pharmacy profession is competency-based and guided by SAHPRA, which is a quality assurance body. And the main exit level outcomes that we address in preparing pharmacists to be able to identify medication errors and prevent them, as well as reporting of adverse drug reactions, ELO, we call them ELO 6, which talks to dispensing of medication. And this is often linked to GPP standard 2.7, which also then requires us to make sure that the professionals we produce are able to interpret, evaluate, and prepare and label medications properly, and further on to provide appropriate actions or information for patients to know what to look out for. And the seventh one deals with pharmaceutical care, which goes further into looking at patient management. And part of that also is ensuring rational medication use and making sure that patients are educated. And these are offered at different levels by various universities. It depends on the program offering that they have. So the basis of this is I thought, let's look at what medication errors are, because we know that they cause a serious public health problem. And I think previous speakers have talked about the detrimental effects in terms of percentages and occurrences. And the most important one, I think that what is important for us to do is to recognize that these errors occur if we talk about medication errors. And our work as educators is to ensure that we prepare students in preventing them. And the main ones that I can think of, or I thought I should highlight, as you'll see, there are other examples: errors of omission, where we often see where patients are not given medication, or a patient doesn't take medication, or commission, where we find prescriptions where patients are given medications that they are allergic to, therefore we have to then take action. So in our preparation, for example, of students, we have to then bear this in mind. And this is done throughout the whole curriculum of training students. So we often try to identify in our teaching the most commonly occurring medication errors, or the ones that when students or professionals are in practice should look out for. For example, highlighting the effects of antithrombotic medicines, where insufficient dosing can result in stroke, or excessive dosing can lead to bleeding. Chemotherapeutic medicines, where often you'll find that there's wrong dose administration, wrong number of days applied. So in our training, we have to make sure that our students are au fait with what is appropriate dosing duration especially when you think of the antimicrobials with the resistance that is occurring. The other one would be, and a good example is epidural versus the intrathecal medications, where if a professional is not aware, you find that a medication error occurs where these are given intravenously instead of intrathecally, which can be detrimental to the patient. Narcotics or opioids, where you find that they are prescribed to patients who are already on these medications. If you do not take proper history and you're not monitoring properly, you'd be able to you might miss this. So we prepare patients as students to be able to identify that in trying to therefore prevent the possible complications such as respiratory depression. The other ones would be, for example, when you're treating diabetic patients, which we know that diabetes is very prevalent worldwide and most commonly occurring in our local settings. So to make sure that students are aware with the fact that hypoglycemic medications, if the glucose levels are not monitored properly, can lead to hypoglycemia. So those are the things that in practice we teach, prepare our students for. And we then often would highlight medications which with narrow therapeutic ranges, or which are often implicated where you have patient medication errors or side effects or hospitalization resulting from inappropriate use, such as insulin, heparin, we already talked about it, benzodiazepines and opiates. So in a nutshell, that's what we sort of, in the 4 years that we prepare students, we try to highlight. So I thought I should give you practical examples of what we do in practice in preparing students. So students are exposed to the dispensing processes, which would cover the 4 phases of dispensing. They are taught this theoretically, they do it practically. And we always emphasize phase 1 to phase 3, and making sure that in phase 1, they're able to identify medication errors or appropriateness of drug therapy to prevent any possible complications. In preparing, in training them to prepare and label medications, we ensure that they do the right thing. If it's an IV that goes to the ward, is properly labeled, and in terms of the route of administration, or if it's a medication that is going to the patient, is properly labeled for the patient to be able to interpret it properly. And phase 3, which we often emphasize from, I think, mainly second year, where they do the practical work, is then educating patients on the possible side effects or adverse drug reaction that might occur and what the patient should do. So we emphasize this through our teaching. And part of the curriculum also covers rational medicine use, where we present theory on these, and in terms of what we're looking at, we'll be talking about the medication error, how they identify them, what they're defined as, how to report adverse drug reactions. We also expose them to practice. So they go to practice where they're expected to also experience and report back on the types of errors they might have come across and the actions that they then developed in mitigating or managing those particular drug problems. Then they present this in the form of portfolio, depending on where you are, of evidence and reflecting on what they have learned. Then the other aspect of rational medicine use, or what we cover, is pharmaceutical care. So the students, we do this theoretically throughout, where we teach students on the theory of pharmaceutical care and ensuring medication safety and patient safety, where they are exposed to real patients. So depending on the settings, the students could be in practice, work-based learning for 4 weeks, or some universities might do it over 1 day, in a week, or it depends. But what is important is we give them practical experiences on identifying patients with potential problems, what they should then do, developing a management plan, how they then evaluate that, so that when they are in practice, they are able to do that. So that's what we do. And basically, I must say, so this is not just limited to this. I thought I should just give you examples of what we do. But I think it's important to realize that even in the teaching of your pharmacology, you always make sure that you teach students on the possible adverse drug events or side effects that they should be aware of and always note, take into consideration when dispensing medication. So, and in postgraduate studies, I just thought, because teaching is not just limited for us to undergraduate, so we have various studies that have taken place, and we try to encourage our postgraduates to participate in ensuring that we prevent medication errors, educating practitioners on how to report adverse drug reactions, and also educate them on all those. So these are just some of the examples of research that has been done, and it's not limited to these in terms of what is done to prepare, to raise awareness about possible drug medication errors. Thank you very much.
Thank you so much, Dr. Matlala, and for that overview in terms of the role of academia. Next, we'll have Anisha Schwartz from the Medicine Information Center, and she'll speak to the role of the MIC in ensuring patient safety. Over to you.
Thank you. Can I just ask if my screen is sharing?
Yes, it is.
Thank you very much. Good day, everybody, and thank you for inviting me to talk to you about the role of the Medicines Information Center in ensuring patient safety. The Medicines Information Center is an essential national resource, and our role is to provide essential medicines info to healthcare professionals to ultimately ensure patient safety and optimal care. When I teach the fourth year pharmacy students at UWC, I always say to them, you picked this profession not to drive a Golf GTI, but to ensure doing the best you can for your patient. And they always have a bit of a giggle about that. But I think we mustn't forget ultimately why we became pharmacists and what our role is. In addition, without unbiased, well-researched and up-to-date information, medicines cannot be prescribed rationally or safely. We need to know about our medicines and what they do and how they interact. How do we do this? The Medicines Information Center provides a free telephonic, SMS, WhatsApp, and email query answering service for general medicines, and we've got an HIV and TB hotline. We have 7 pharmacists with lots of experience, and if there is a query that we as a pharmacist cannot answer, we get support from a clinical consultant. We have access to those from UCT, Groote Hospital, Red Cross Children's Hospital, and Tygerberg Hospital. And as we identify knowledge gaps over the years, we sort of, from the queries that we have received, we know what people don't know about. We develop clinical tools and educational material to try and address those knowledge gaps. We have a website where you can find all this material. We also have developed a free SA HIV and TB hotline app, which I'll show you a little bit more about later. And then we have also, over the past 2 to 3 years, started the process of digitizing the South African Medicines Formulary. We all know that every pharmacy has to have a SAMF to be legally compliant. And we just thought we need to move with the times and we need to provide this as an app and a website. And this has now been available since the 14th of Feb. It was launched. Who answers the questions when you call us? We basically have specially trained pharmacists, and we are in the division of clinical pharmacology at the University of Cape Town. So we have access to a whole lot of experts, and we subscribe to the latest information databases and reference sources, and obviously also have access to the whole of the UCT library. How do we answer these questions? So this is just an example of the electronic record that we keep on all the queries that we receive. This was a person, a doctor that phoned in about a 37-year-old female who developed a drug-induced liver injury on TB treatment, and they wanted help with that. And as you can see, we take down a lot of details on the caller, the patient, all the medication they're on, the laboratory results. We keep a record of the query as well as the answer and the references used to answer that question. Then, as I've said, we've developed clinical tools and educational material over the years to address knowledge gaps. And this is one tool that I think would be very useful for pharmacists, especially now that we're going to hopefully one day get pharmacist initiated art. And this is an EML antiretroviral interactions table. So basically what we've done is we've looked at very many references and summarized interactions between all the drugs on the EML and all the antiretrovirals available in the public sector. And we basically tell you whether there's an interaction or not, and if there is, how to manage it. Please note that dolutegravir, which is our new first-line antiretroviral in South Africa, doesn't have a lot of drug interactions, but unfortunately, it has some with OTC products because it forms complexes with metals di and trivalent, like calcium, magnesium, aluminium. And you actually need to know about this and advise your patient to take the two together with food or to separate the dosing. Otherwise, you're going to run into problems because your dolutegravir levels are going to be much lower and your patient is going to fail therapy, and that is disastrous for them. Can you hear me?
Yes.
Yes, we can.
Sorry, my screen was just stuck. We have a website, and here you can find all our tools. On the left, you'll see you can download all our clinical tools and posters, find our contact details, and we also, on a very regular basis, put interesting news items up for people to read and to stay up to date. Then we move on to our SA HIV and TB hotline app. We developed this about 6 years ago. It's available for both Android and iPhones. It's got a nice feature. It can be used offline because a lot of our healthcare workers don't necessarily have access to data or the internet, especially if they're in the rural areas. All the information on here, well, the posters are printable and shareable. And it has information on drug interactions, adverse drug reactions to the drug-resistant TB medication. It's got monographs. It's got dosing tools for adults and children. And also all our guideline posters that we have developed over the years are on this app. Free to download from the app stores and very simple and easy to use. So I encourage all pharmacists to go have a look and download this app and use it. Then, as I've said up above, we've spent quite a long time developing a digital SAMF over the last 2 to 3 years. It's available as an app and as a website. It basically, on the phone, once you open the app, it looks like this. The search function is quite intelligent. Even if you make a spelling error, it will still find your medication that you're looking for. You can use multiple terms, combine them. You can also use generic or trade name, as well as disease and medical conditions. So basically, you type what you're looking for in the search box, it will search, you then click on it, and The information, exactly as in the book, will come up, including links to the introduction section and clinical notes. On the website, this is what it looks like on the website. To me, the website is slightly more user-friendly because the screen is much larger, so it's easier to read. And here we have an example of a monograph for valproic acid. And just to remind everybody, we've been trying to get this message across via Dear Doctor letters, and still we find so many people prescribing valproic acid or sodium valproate in women of childbearing potential. Please remember that valproic acid is contraindicated in pregnancy and in women of childbearing potential unless there's absolutely no other option to use. Then just to leave you, I'm on my last slide, thank you. So we want to leave you with a solution. I think that as pharmacists and healthcare professionals, we all realize that prescribing safely can be quite complicated, and the Medicines Information Center is here to assist you. If you have a complicated patient, please call us, please use our references. We're very, very happy to help you. Thank you.
All right. Thank you so much, and thank you for sticking to time. We will now move on to our last panelist before we go into the Q&A, Dr. Vatiswa, and she'll speak to the role of pharmacists in ensuring patient safety. Over to you.
Thank you. May you please make it thank you. Yes. Colleagues, you may proceed to the next slide. Right. I always say I see pharmacovigilance as a table with 4 legs, and those 4 legs being adverse drug reactions, adverse events following immunization, medication errors, and poor quality medicines. Next slide, please. Now, what is pharmacovigilance? It is a science and activities relating to the detection, assessment, understanding, and mostly prevention of at least the known adverse effects. And let us look at the adverse drug reaction. As already it has been mentioned by the previous slides that it's a noxious and it is unintended. Next slide. And it happens at normal prophylactic doses. Right. If we look at the epidemiology of these 8 Rs, they can be a leading cause of death. And what is most important is that they can be preventable. Next slide. Let us look at the well-known arachidonic acid pathway, talking to the NSAIDs. If we look at the pathway, the COX inhibitor there, the COX enzyme, once you inhibit that pathway where you get your prostaglandins and thromboxanes being produced, you inhibit that, then you get the second pathway where you get your leukotrienes dominating. When your leukotrienes dominate, we all know that they can lead to angioedema, they can lead to the obstruction of the airways. So meaning that we know that information, so we can use that information to prevent the asthmatics from using the NSAIDs. So basically would rather use the safer alternatives rather exposing them to NSAIDs. Next slide, please. What is the aim of pharmacovigilance? Basically, it is all to improve patient care and safety, improve public health, contribute to assessment of benefit, harm, and the effectiveness of the medicines that we're using, and most importantly, communicate what we get or what we find or what we observe at ground level. Next slide, please. Why pharmacovigilance? It has already been mentioned that the medication before they get registered, they are under stepwise approach of developments. There are clinical trials that are being conducted, and then they will be registered. Then post-registration, the medicinal product is now being used by population that were not part of the clinical trials. Different genotypes, different cultures, different beliefs, different socio-economic problems, etc. Next slide, please. So basically, the clinical trials are artificial environments. Next slide, please. Well, the benefit of pharmacovigilance is it has already been mentioned that it can lead to the withdrawals of the medicinal product from the market, and also can lead to the new developments on our EMLs, essential medicine list on formularies. Next slide, please. I've already mentioned that the importance of pharmacovigilance is that those, as there were clinical trials that have been undertaken, but the participants were not actually our own population that we serve, you know. So what's important is, as we report the adverse drug reactions or the IFEs, you know, we are then developing our own data. We are completing our own safety data. So that is the main importance of pharmacovigilance. It is to collect our own patient population data. We're dealing with patients with HIV, we're dealing with patients with cancer, etc. Most clinical trials do not include vulnerable population like your pregnancy, children, you know, elderly, and post-marketing. We use those medicinal products in such patients. Proceed. Next slide. Thank you. So we've already mentioned this one. We can skip this one. All right. Let us now look at how do we detect, because practically most people are saying, but then how do we detect ADRs? It can be via subjective report, what the patient tells you, or an objective report. Objective report is whereby, as a healthcare professional, you can observe, you have a direct observation of the event. You can actually see the rash, that you can actually see perhaps the angioedema, you know, and there can be abnormal findings from the physical examination, your laboratory tests, for example, elevated LFTs in patient taking TB medication, diagnostic procedures. Next slide, please. What is important is that not all reactions can be maybe from the medicinal product. We must exclude other possibilities, and from that, we then have what we call causality assessment. Causality assessments, they can be from different different methods can be used. The most popular one is Naranjo. I know that there are new ones that are current, so hence I'm saying there is a lot of assessments that can be used, but most importantly, we need to do the causality assessment to actually detect whether this is due to a medicinal product, or it can be a condition, or maybe food or something else. Thank you. Next slide. Next slide. You may skip this one. Right. What's important is, from your reporting, we're collecting data, our own patient population data, and then that data is analyzed. The most important part is the response. What do we do after data has been analyzed? Next slide, please. We can have trainings of our healthcare workers from the findings. Medicine can be recalled by SAHPRA, and our own NEMLEC can then review guidelines and formulary. So as we know that pharmacovigilance is a subcommittee of PTC. So at institutional levels, we get to have champions that will champion the facilitate the reporting of all these adverse drug reactions. So we feed to our PTCs. Then the PTC, provincial PTC, will eventually feed our findings to the NEMLEC. Then you get this review of the guidelines and formularies. Next slide, please. What's of importance is that when you have identified an adverse drug reaction or any adverse event following immunization, is that you need to report, you need to manage that patient, because that patient is still a human being that needs to be managed and followed up. Most importantly is the documentation of the event. By documenting the event, you are now communicating with the future healthcare worker. And what has not been recorded or documented, it has never happened. So you need to put it on the medical records, on the clinical notes, not via the Dear Doctor note, no. Write it on the clinical note that, excuse me, what has happened, describe the event, describe the reaction, how did you manage the reaction, what was the outcome. Follow up the patient until they are fully recovered. Who is responsible to report? Any person that is a healthcare worker is actually their responsibility to report. Next slide, please. Well, this is just a summary of the steps following a suspicious ADR or an IFI. You report, you analyze, then we share the findings. Next slide, please. Sharing the findings makes it, you are actually distributing the information to other healthcare workers. So through pharmacovigilance committees, and the pharmacovigilance meetings, then that's where you get to share the information, and we learn from all these reported cases. So the benefits of pharmacovigilance, really, it is beyond safety. So we're looking at the safety, quality, and resistance, and the impact it has in improving the quality of lives of our patients, the impact it has on the supply chain, because sometimes there can be a problem with the supply chain. Then we also play a role as the pharmacovigilance team. Next slide, please. Now let us look at the other leg. I've already spoken about adverse drug reactions with IFIs. The process is similar. And then the medication errors. Now, mostly here, our colleagues will feel that as pharmacists, we are being policemen when we pick up the errors. But I always say the errors, medication errors being identified, are not actually pointing a finger to any healthcare worker, but rather they are pointing a finger to the healthcare systems. If there is an error, then there has been, it is associated with a failure of a healthcare system, not not to blame a healthcare worker. Next slide, please. So the objectives basically there to prevent medication errors, develop the strategies to reduce harm to patients, improve by implementing new strategies, and monitor and evaluate all those to improve the quality of healthcare at the end of the day. Next slide, please. Next slide, please. Right, this is my last slide. So in summary, colleagues, I would like to end by saying that with medication errors, if you cannot have one person dispensing and performing all three phases, phase 1, phase 2, phase 3. At least have 3 different people performing phase 1, have another one for phase 2, and have another one for phase 3. So that at least one person out of those 3 can pick up the error if there is any. So, and then the 4th one was the poor quality. Poor quality is also our responsibility at institutional level to report the products that we receive. And by so saying, colleagues, thank you so much. That was my last slide.
Thank you. Thank you so much. Thank you so much, Dr. Batiswa. We've got several questions in the chat. Some have been answered, some have not. I see Mr. Yusuf is typing. Maybe instead of typing, you might want to answer this question, Yusuf, in terms of how to differentiate adverse events caused by medication error and not due to suspect drug itself causing the event.
So I think what we could do is, if you are not sure, just we encourage everybody to report it to the health authorities and to the pharma companies. Further analysis can be done, and what we normally do from a pharma company perspective is that we try to maybe dig in with a little bit more questions in order to find out exactly what the issue was. So we encourage you to first report it, and then even if you're not sure about it, we can still get more information and do further analysis to see whether it was the medication or it was a medication error.
All right, thank you so much, Yusuf. I see there's also a question for Busi, and I see you're typing. Maybe you might want to respond to the question on if all medication errors are assessed seriously. And also, I think as you are on that, you can also elaborate on the response that you've given on the codeine pandemic and the use of social security or ID numbers for prescription and avoiding duplication. Over to you, Busi.
Thank you. Yes, medication errors, they need to be reported to the regulatory authority. Actually, there are many different medication errors. Could be because of prescribing or dispensing or administration. And it could also be a health system issue which need to be looked into for perhaps maybe for the healthcare professional whom might have done this medication error. It could be that they are short-staffed, or yes, they have a lot of patients to take care of. So yes, they are one of those adverse events that need to be reported to SAHPRA and are taken very seriously. So there's another question that you said I should reiterate on. It's on, was it the one on codeine?
It was more on the codeine pandemic and the nature of pharmacy hopping, to say, is there a system that uses an ID for the prescription, or to avoid people taking codeine from one pharmacy to another? Is there any system that can be used? And I see you've responded.
Yes, in the pharmacies, what they do now is they would request the patient or the consumer to bring their ID, so that when you come on a certain day, on Monday, you come and say you need 20 codeine containing medicines. And again, on a Wednesday, you come again and you need those tablets. So they would see that you perhaps are not using it for what they're indicated for. So that particular pharmacy would know that for this person, we gave them this medication on a Monday, and today we are not going to give them. But my concern was that then other patients would then go to other pharmacies. They would receive codeine from one pharmacy with an ID and receive another codeine containing medicine from another pharmacy, because the systems are not linked. They wouldn't know that this person is coming to us at the same time and getting this codeine containing medicines. So I think that that's where the issue is, that maybe we have to look into linking the systems in the pharmacy. But currently, yes, they require IDs from them.
All right. Thank you. Thank you so much for that, Busi. I think the one question that might also need a bit of just last, I see we're almost to our own time actually, and I think we'd have loved to respond or to have most questions responded to. I think what I will request, what I'll mention is that we will have a recording that will be shared with people that have been that are in this webinar, and then also we'll continue to pose these questions to the relevant panelists and hope that then you will receive responses to the questions that you have answered, especially for those that we can see their names and we can link them to the emails that they use for registration. Otherwise, we do not even have time for our panelists to make concluding remarks. But I want to pass my thanks. It's been a very packed program. Thank you so much to all the panelists for sticking to time, and also to all the participants for sitting this through to the end, and have a wonderful day. Thank you.
Thank you. Bye.
Thanks. Bye.